Good day, everyone. I am Dr. Supache Basit, your professor for today, and we will be discussing about the molecular and serological diagnosis of COVID-19. The coronavirus disease 2019 is actually caused by the novel coronavirus severe acute respiratory syndrome coronavirus 2, so also known as the SARS-CoV-2, and it was formerly known as the 2019 nCoV or novel coronavirus. It first appeared in China, and after that, it has actually spread all over the world. So when we say COVID-19, we are actually pertaining to the disease itself. But when we say SARS-CoV-2, we are actually referring to the etiologic agent, which is the formal name of the virus. Okay, formal scientific name of the virus. Okay, so the diagnostic sensitivity, specificity, and accuracy concerning suspected COVID-19 infection based on controlled testing and performance data from clinical settings is of vital importance in the context of limiting the scope of coronavirus pandemic. So if you notice, countries that have done mass testing are the ones that can actually avert or control the pandemic itself. Okay, so based on our experience, of course, unreliable and unproved tests may not at all detect patients with active infection, or worst of all, it may incorrectly indicate COVID-19 negative patients as positive, or this would actually hamper the healthcare effort. So that's the problem if a COVID-19 is tagged as a positive patient. Okay. However, it is also equally dangerous to have a false negative, because if it's false negative, then a particular person may have a false sense of security. And if that person has a false sense of security, so he would think that he is COVID-19 negative, and there you go, he will actually start spreading the infection. So, a rapid presumptive diagnosis based on clinical assessment and, of course, epidemiological characteristic is critical to ensure appropriate patient care and, most importantly, control viral transmission. Thus, it will all contribute to the overall disease control. That's the reason why our role as a medical technologist, as a medical technologist, being in the front line of all this pandemic is actually very important. So, just so to give you a background, what are the clinical diagnoses? So how would you know if a person has a COVID-19 disease? Well, it's actually redundant because COVID actually refers to the disease. Okay, anyway, so asymptomatic infection has been reported in many settings, but some patients develop clinical disease at a later stage of infection. Yes, at first, you will have actually a mild or moderate symptoms and you would think that you're okay with it. But the thing is, cytokine storm happens usually at the 10th day. So that is when you cannot really, your oxygen saturation becomes very low, and that is the time that patient will actually go from mild, moderate to severe. Okay, however, the proportion of truly asymptomatic infection, so when we say truly asymptomatic patient, these patients do not feel any slight symptoms at all. Okay, so the proportion of truly asymptomatic infection is unclear, of course, because these particular people, since they are asymptomatic, they wouldn't warrant themselves to have them tested for COVID-19. But some estimates indicated that up to 80% of infections do not result in overt clinical signs of the disease. This is somewhat disturbing because these asymptomatic patients, though do not show any signs and symptoms, could still remain infectious or contagious. Okay, so you have to remember several factors, okay, in clinical diagnosis. Number one, patient with acute respiratory illness. When you say acute respiratory illness, this particular patient may have fever, at least one sign or symptoms of any of the respiratory disease, such as coughing or shortness of breath, or medically speaking, we call it dyspnea or difficulty in breathing. and a history of travel to or residence in location reporting community transmission of COVID-19 disease during the last 14 days prior to symptom onset. So unfortunately, we are in the so-called NCR bubble, and this is where a high community transmission is actually taking place. So each and everyone has to be careful. Number two, a patient with any acute respiratory illness who has been in contact with a confirmed or a probable COVID-19 case in the last 14 days prior to symptoms onset. So, if you have been associated or if you have a contact with a person with known positivity with COVID-19, then you have to watch out yourself, okay, for the next 14 days. Okay. And number three, a patient with severe acute respiratory illness. So when you say severe, you have one, fever, and your fever is accompanied by at least one sign or symptoms, which may include coughing, shortness of breathing, and this particular person is said to be severe because that person would now require hospitalization. Okay? And in the absence of an alternative diagnosis that fully explains the clinical presentation. So actually, laboratory test goes hand in hand with correlating with the clinical presentation of the patient. Okay, so here's some of the figures that you might want to ponder in. So for example, 81% of laboratory confirmed COVID-19 patients develop mild to moderate disease, which includes non-pneumonia and pneumonia cases. Okay? And then 14% have severe disease. As what I told you, dyspnea, difficulty in breathing, tachypnea, or blood oxygen saturation of less than 93%. You need at least actually to be stable about 98%. And then the PaO2 and FiO2 ratio of 50% of the lung within 24 to 48 hours. So this is kind of severe because your lungs may be in distress for this particular situation. And then 5% of cases reach critical state. So this one is rather dangerous because here there would be respiratory failure and then septic shock because of the infection, a co-infection that has actually reached the bloodstream, and or multiple organ dysfunction or failure. So this particular critical state most likely will result to death. So as you can see, this illustration will tell us what are the possible signs. So you have fever, and then gastrointestinal issues because some patients are actually reporting to have diarrhea, and then myalgia or arthralgia. So myalgia refers to the muscle pain, and then pain in the joints, or that would be the arthralgia. Dry cough. So when you say dry cough, the coughing is non-productive. And then shortness of breath, and then body ache because body ache is due to many factors because, for example, inflammatory cytokines are actually being released. Okay, and then other symptoms of COVID-19 would include headache, sore throat, fatigue, chills, loss of smell, and loss of taste. Probably because your olfactory nerves are actually being invaded already by the virus itself, and even the receptor for your gustatory sense is also being invaded by the virus. So the receptor and the nerve transmission in that particular receptor is now being blocked. So what are the risk factors? So risk factors would include if you are above 65 years of age, or people with pre-existing concurrent conditions such as cardiovascular disease, hypertension, diabetes, chronic respiratory disease, immunodeficiencies, cancer, and obesity. Okay, so these are the risk factors because these patients are actually more predisposed to have the severe to lethal episodes of COVID-19. So as a medical technologist, of course, our concern would be our concern would be for the diagnostic value of SARS-CoV-2. So let's talk about virus isolation. Actually, it's actually difficult to isolate the virus. That's the reason why at the early stage, coronavirus, on the early years, prior to the discovery of SARS-CoV-2, um, they've been studying, very little known is about coronavirus. And they've been studying coronavirus mainly through electron microscopy. Hence the term corona, because of the petal-like structure or the crown-like structure that surround the virion itself. So later on, we will discuss what are the parts of the coronavirus. And then, of course, with the advent of diagnostic test, so it is of course expensive to have electron microscope every now and then. So molecular and serological tests were actually developed. So the since this particular lecture is intended for clinical laboratory science students, we will be focusing on molecular and serological tests for COVID-19. So, but before that, of course, let's talk about biosafety for handling specimen. So, the World Health Organizations had actually recommended that all procedures performed with COVID-19 be done only by trained professionals and should take place in a laboratory with an appropriate level of biosafety. Okay, so actually there are two main types of diagnostic assays. So the first one is non-propagative. Okay, so when you say non-propagative or non-propagative, you are not propagating the virus. You are simply looking for the presence, let's say, of the nucleic acid or viral antibodies or viral antigen. So this includes the nucleic acid amplification test. So anything that would require amplification of nucleic acid, so that would be the NAATs. So an example of NAATs would be PCR, RT-PCR to be exact. And then sequencing, meaning to say, not only you amplified the nucleic acid, but you studied the actual nucleic acid sequence, the actual nucleotides. You study it, okay, and have a thorough bioinformatics studies. So before you can do that, that would entail or that would require you to have sequencing. And some serological tests can also be done, such as ELISA, but all of these should be performed in biosafety level 2 laboratories, provided that the initial processing, meaning to say, before the virus inactivation of sample, takes place in a biological safety cabinet. You know, if you are already inside a molecular biology lab, you are actually much safer as compared to persons doing the swabbing, because at that particular stage, the virus is still viable. And then, and another equally dangerous people are, not the people, but equally dangerous occupational risks are those people who are inactivating the virus, because before inactivation, it means that the virus is still viable. But if you have already received the inactivated virus, then you are at a much safer stage of testing. Okay. However, procedures that involve propagative virus work, such as virus culture, isolation, or neutralization assays, should be performed in laboratories equivalent to biosafety level 3 using validated practices. Meaning to say, propagative virus, you are cultivating the virus. You are culturing the virus. So, nevertheless, the work team must use appropriate personal protective equipment, and that would include eye protection, which could be in the form of goggles or a disposable face shield, a respirator or face mask, a long sleeve gown, and gloves, and follow all standard operating procedures regarding sample collection and handling, and also that would also include the proper donning and doffing of these PPEs. So SARS-CoV-2 infection can be detected in a variety of clinical specimens. So of course, you all familiar that the most common would be your nasopharyngeal. So that would be your nasal swab, and then oropharyngeal aspirate or washes. So actually, in our country, we both do the nasal swab and the or oral swab or the throat swab. So nasopharyngeal or oropharyngeal swab, sputum, tracheal aspirates, and bronchoalveolar lavage. So aspirates, lavage are kind of more invasive. So of course, swabbing would be more convenient and less invasive as compared to aspirates and lavage. So the median duration of SARS-CoV-2 shedding in respiratory sample is actually 24 hours. Okay, with an interval of 18 to 31 days in survivors, but shedding can last up to 42 days. So what does it mean? It means that more or less you are still infectious. Okay, because you still continue to shed viruses. So there has been an article, or there was a published article that I've read that a person who is already negative with RT-PCR using the oral swab or nasal swab may still shed viruses in their feces. Okay, so that's possible. So the collection of specimens other than sputum from the lower respiratory tract should be considered only in special situations. So this is where the tracheal aspirates or bronchoalveolar lavage will come into play. So a nasopharyngeal swab collected with a fiber plastic shaft swab, the one that you can see in the illustration here, is the preferred choice for swab-based SARS-CoV-2 testing because it provides reliable results while not being too invasive. So we do not want to use cotton because cotton may have calcium alginate, and wooden swabs are not recommended because they may contain substances, so inhibitory substances that can inactivate some viruses and may even inhibit PCR testing. So this may result into false negative outcomes. Okay, so when collection with nasopharyngeal swab is not possible, so there are other options such as the oropharyngeal swab. So in fact, in the Philippines, we are using both nasopharyngeal swab and oropharyngeal swab, and then another options are nasal mid-turbinate swabs. Wow. Anterior nares or nasal swabs are also acceptable alternatives. So swabs should be placed immediately after collection in 2 sterile tubes containing 2 to 3 ml of a viral transport medium or the VTM to preserve viral integrity. So usually we have a different site for swabbing, and then it has to be placed in VTM, and then it will be sent in the molecular laboratory. So upon collection and with the appropriate storage medium, specimens can be stored between 2 to 8 degrees for up to 72 hours. In cases of delayed testing or shipping, samples should be stored at -70 degrees or below. At the early onset of COVID-19 testing in the Philippines, we do not have yet, there's only one molecular biology testing center in the Philippines. So some of the samples are being sent or being shipped to Australia. So can you just imagine the expenses that will incur because it will of course you have to store it at -70 because it will take several days before that shipment reached Australia, and several days before you can get the result. You can have the result back. Okay. So specimen for diagnosis. So in addition to respiratory tract specimen, SARS-CoV-2 can also be detected in other samples such as stool, anal swab, and blood, but not in urine. So what does it mean if you are able to find SARS-CoV-2 in the blood? So it means that SARS-CoV-2 detection in blood is not frequent and it is associated with disease severity. So meaning to say the patient has already a viremia or the virus is present in the bloodstream already. Okay. The detection rate of SARS-CoV-2 in fecal specimen is similar to that of pharyngeal swab. However, it is very important to take note that fecal viral shedding appears to occur for a longer period of time. Imagine what I told you before, 42 days. Okay? Serum and plasma samples are used for serological assays, meaning to say, if you want to do antibody testing, that's the time that you'd have to use serum and plasma, especially 1 week post-infection. So the median seroconversion time for total anti-SARS-CoV-2 antibodies, both IgM and IgG, would be 11 days, 12 days, and 14 days respectively. Meaning to say, IgM first appear 11 days post-infection, while IgG, being the secondary response, appear 14 days after the infection. The total anti-SARS-CoV-2 appear 11 days, IgM appears after 12 days, and then IgG appears after 14 days. Okay. For diagnosis and testing, there are different types of diagnostic tests available. So some diagnostic tests detect infection, while others would detect an immune response. So if you want to know the immune response, of course, antibody testing would be very much appropriate. So testing plays an important role in a public health response to COVID-19. Without mass testing, there's no way for us to know who is infected or not. And if we do not have any knowledge who's infected or not, then it's quite difficult to isolate or to quarantine them because some of them remain to be asymptomatic. So let's talk about the virus itself. So the coronavirus have 4 structural proteins. Namely, we have here the spike protein. Okay, so you can actually see here the spike protein. Okay, so this is the spike protein. And then we also have the nucleocapsid because it is actually here near the capsomere. And then we have the envelope. So the envelope is the lipid membrane bound. Okay, lipid made up of lipid. And then we have the actual membrane, the membrane glycoprotein. Okay, so the RNA, this is the RNA. So the RNA is actually responsible for infectivity of the virus. So during an infection, the body's immune response makes antibodies, or we call it immunoglobulins, that bind themselves to the structural proteins. So it is hoped that these particular antibodies are actually try to neutralize the virus. So the spike and the nucleocapsid are the main proteins, okay, which trigger an antibody response in humans. Meaning to say, the S and N proteins are the antigenic proteins. Okay? So when you say antigenic proteins, they are the ones that would stimulate the immune response or antibody response in humans. So as a result, we humans would be producing IgG and IgM. So the first antibody that will be produced is the IgM, since this is known as the primary response, and then it will be followed by the IgG. So again, the antigenic proteins are the S and the N proteins. Okay, so what do the diagnostic test detect? Okay, so as you can see, we have two main segments here. Okay, the first diagnostic test would detect the virus, and the second diagnostic test would detect the immune response itself. So there are 2 types. So we have the nucleic acid amplification technique. So this is the general term that would require amplification of RNA or nucleic acid. So RT-PCR is just an example of NAAs. And then the other one would be the COVID-19 viral antigen. So what's the difference between the RT-PCR and the antigen testing? So the RT-PCR detects the RNA, the presence of the genetic materials. Okay? Whereas the COVID-19 viral antigen testing detects the protein that is responsible for the production of antibodies. So these proteins are the N protein and the S protein. So these are the ones that are being detected in the antigen testing. On the other hand, when you say immune response, we are trying to detect the antibodies in response to the N and S proteins. So these antibodies could either be IgM or IgG. So IgM is the primary response and IgG is the secondary response. So timing of testing is very important. Okay, at the early onset of the pandemic, wherein the rapid antibody testing has become very popular because it's cheaper, um, it's actually it's actually less comfortable to have your blood taken rather than the swabbing itself. So many people are trying to say, why don't we do antibody testing? Why don't we do antibody testing instead of RT-PCR? Well, this is the reason. So during the incubation period, um, it's quite difficult to detect the virus or the virus itself, even the antibodies itself. Meaning to say, if you do testing at this particular point, you'll be negative. But it's a false negative. It doesn't necessarily mean that you do not have the infection. Now, as you can see, as your symptoms start to occur, the virus can now be detected. Okay? Meaning to say, there's a big chance that you will be positive with RT-PCR and antigen testing at this point. Okay? But can you do antibody testing? No one is actually interfering you to do antibody testing, but you have to be very careful when it comes to interpretation. So most probably IgM will be detected here, and then it is followed by IgG, but eventually the titer of IgM becomes very low, whereas IgG becomes more long-lasting as compared to IgM. Okay. So later on, we will try to determine what are the importance of this particular testing. Okay, let's talk about molecular testing. So as what I've told you, molecular testing is also known as the diagnostic test, the viral test, molecular test. The general term, though, is the nucleic acid amplification test, and RT-PCR is just one of the examples of nucleic acid amplification test. Although in this lecture, we will dwell more with the RT-PCR because that is the one that is more popular as compared to another kind of NAAT, which is the LAMP or the loop amplified mediated plasmid test. Okay. And the other one is the how is the sample is taken. For molecular testing, it can be taken through nasal swabs, either shallow or deep. I actually experienced it, but fortunately, the swabber, we call it the swabber, or do we call them the swabber, or the one who performs the swabbing, just have a shallow penetration, is it the proper term? Basta, shallow swabbing in my anterior nerves. Okay? And then saliva, some test. Okay. How long does it take to get a result? So, technically speaking, in less than an hour, you can have the result. But then again, of course, you have to understand the traffic in the lab. So you have to pull all the samples for the day, and then you have to consider how many wells are available in order to run a batch of testing. So you cannot demand medical technologies to release the result in an hour. But technically, it can be done because if you are the only, if they will devote their time and energy for you alone, yes, that can be done. But that's not the reality. Okay, so that's the reason why you have to wait for about 1 to 3 days before you can get the result. So some tests may take longer in some locations depending on the testing capacity. Okay, so in molecular testing, is another test needed? No, not usually. This type of test is typically highly accurate. That's the reason why we call it the gold standard and usually does not need to be repeated. Some may indicate that need to retest in certain circumstances. So let's say, for example, I have been rebuked, but let's say I have been tested positive, and then During the convalescent period, I would want to know if I'm not anymore contagious, so the doctor may prompt me to have another test performed. What does it show? Well, if you're positive with molecular testing, it can diagnose active. So take note of the word active, COVID-19. Okay? So sometimes may also diagnose influenza and other respiratory viruses depending of course on the primer that you've actually used. But in the context of COVID-19 testing, if you are positive with RT-PCR, it does indicate active COVID-19 infection, therefore you are contagious. What it can't do? Well, of course, molecular testing would also have its limitation. So the limitation is that it cannot show if you ever had COVID-19 or were infected with a virus that causes COVID-19 in the past. So it cannot show past. Okay. How about antigen testing? Antigen testing is also known as the diagnostic test, viral test, and rapid test. Although according to WHO, we do not call anymore the rapid antigen test because the rapid antigen test only pertains to the lateral flow chromatography. But there are some antigen tests that is not necessarily rapid because there are some machines that can also do antigen testing, such as the chemiluminescent assay. Okay, so how is the sample taken? The same as the molecular testing, but mostly through nasal pharyngeal swab. Okay, how long does it take to get a result? Some may be very fast. Yes, that's true. Between 15 to 30 minutes, depending on the test, but you cannot demand, okay, depending on the traffic again of the laboratory. Of course, they need to pull all the samples together before doing the test. But if we're pertaining to the immunochromatographic assay, so it can be done within 15 to 30 minutes. Okay, is another test needed for antigen testing? Well, maybe. Positive results are usually highly accurate, but take note, there is a chance for false positive, especially in areas where very few people have the virus. And negative results may need to be confirmed with a molecular test, especially if you actually show signs and symptoms that are related to COVID-19. What does it show? Well, if you're positive with antigen testing, it means that you are diagnosed to have an active COVID-19 infection. I mean to say you are infectious also and you have the disease. What is the limitation? It may not detect an early COVID-19 infection. Unlike RT-PCR, the molecular testing is actually more sensitive. So your healthcare provider may order a molecular test if your antigen shows a negative results, but your symptoms are actually consistent with that of the COVID-19. It also cannot show if you ever had COVID-19 or were infected with COVID-19. Okay, so usually, it is actually not recommended to perform antigen testing for asymptomatic patients. How about in antibody testing? So antibody testing is also known as the serological test, serology, blood test, or serological test. So the sample is taken by means of blood from a finger stick or by means of venipuncture, especially if you want to get the serum. So how long does it take to get the result? Well, in some day, particularly if we're talking about the point of care locations, same day, not some day, sorry. Okay, 1 to 3 days, especially if you're sending it in a laboratory for processing. But again, like your rapid antigen testing, it can actually be seen immediately. Okay, within 15 to 30 minutes, I suppose. So is another test needed? Sometimes a second antibody test is needed for accurate results. Okay, you know what? After you have been vaccinated, so some people may wait for several days before they will perform antibody testing to check if they have already produced antibodies against COVID-19. What does it show? Well, it shows that you've been infected by the virus that causes COVID-19 in the past, or it may also signify that you have been successfully vaccinated. because already you already established an immune response against the COVID-19. So what is the limitation? It cannot diagnose COVID-19 at the time of the test or show that you do not have COVID-19. So being a positive in antibody testing does not necessarily mean that you are positive with or not positive with COVID-19. So let's say, for example, there is a situation that mass testing or a certain laboratory is already overwhelmed. So what do we do? Okay, so please screenshot this one and try to study. Okay, because for example, if a patient is already recovering or has tested negative twice, then discharge after the additional 14 days self-isolation. So these are the guidelines, the interim guidelines that were actually um, uh, recommended by the World Health Organization. Okay, now let's talk about cross-reactivity. Okay, so what do you mean by cross-reactivity? Cross-reactivity occurs when antibodies produced against proteins of one type of coronavirus can occasionally bind weakly to proteins of another type of coronavirus or cross-reaction. So prior to SARS, okay, there were actually four types of coronavirus. Okay, the human coronavirus HK1, the human coronavirus NL63, the human coronavirus OC43, and the human coronavirus 229E. So this particular coronavirus usually causes common colds, but can cause severe disease in vulnerable groups. So before the advent of the SARS, okay, these were the known coronavirus. But in 2003, between 2002 and 2003, there appears the SARS-CoV-2. This is the severe acute respiratory syndrome, or SARS-CoV lang pala, sorry. And then it is followed by the MERS-CoV, or the Middle East Respiratory Syndrome. So fortunately, it was just confined in Middle East. But now, in 2019, you have the COVID-19, which is now caused by the SARS-CoV-2. So all of these coronaviruses may interfere with one another, and it results to the so-called cross-reaction. So tests that detects for COVID-19 virus may cross-react with other coronaviruses and eventually give false positive results. So that is one we have to consider during the laboratory diagnosis. So usually they would report that if a person has common colds during the swab, so that person would most likely yield positive in COVID-19, and then there are some reports that when they do the testing 2 days after, where they do not have any more common colds, then they are usually negative. But again, without any empirical data to prove, so those stories remain to be anecdotal. So let's talk about the RT-qPCR. The RT-qPCR. So genetic tests are meant for the identification and differentiation of SARS-CoV-2 in the material or specimen collected from patients with COVID-19 symptoms. So how do we do it? So by detecting RNA sequences unique for SARS-CoV-2. So when you say unique, that is very important because we do not want to show cross-reactivity. Okay? Cross-reactivity will result to false positive. So that's the reason why if RT-PCR is very sensitive, it is also very specific. And the reason why it is very specific because at present, this particular RT-PCR are actually meant to detect the ORF1AB, the E, the N, and the S gene sequences, and in various combinations. So as you can see, the entire thing here, the green thing here, these are the RNA of the virus, the nucleic acid of the virus. So if we're going to sequence it, so this is the genome of ORF1A, this is the genome of ORF1B, this is the sequences where we can find the S, and then this is the sequences for the E, or for the M, and for the for the E. Okay, so these are being detected. So these particular material, these particular sequences are being detected, and not just detected, quantified. So that's the reason why we have qPCRs. These are being detected and quantified by means of RNA copies, okay, in this molecular testing, making RT-PCR as specific and sensitive at the same time. So the principle is RT-PCR is a variation of PCR. PCR, as we all know, is the polymerase chain reaction. So the two techniques use the same process, except that you have an additional step in RT-PCR. Coronavirus is an RNA virus. Okay, so since it is a coronavirus, you need to convert RNA to the cDNA or the complementary DNA, okay, to allow for amplification. So that's what you call the reverse transcription. So this means that PCR is used for pathogens such as viruses and bacteria that already contains DNA for amplification, while RT-PCR is being used for those containing RNA that needs to be transcribed to DNA or for amplification. So since coronavirus is an RNA virus, you have to convert it first to DNA before you can actually amplify it. Okay, so that's the principle of RT-PCR. Okay, so as you can see here, this is the RNA of the virus. Okay, so viral RNA is actually uh, uh, it's not double-stranded, so it is single-stranded. Okay, so the reverse transcriptase enzyme would be responsible for reverse transcription. So as you can see, once you have added primer, you now produce the complementary or the cDNA. Sorry. So you produce now the complementary DNA. And then after that, from this step onwards, it is as if you are now doing the PCR. So that's why it's RT-PCR. If the virus, let's say for example, the coronavirus is a DNA. So let's pretend that the coronavirus is DNA. If the coronavirus is DNA virus, there's no need for us to do this step anymore. So can you just imagine, it will be much cheaper to do molecular testing if had the coronavirus been a DNA virus. But since it is an RNA virus, there's a need for us to reverse transcribe it by means of the enzyme reverse transcriptase in order to convert the viral RNA to the cDNA copies. Then after that, you now do the usual PCR, which includes denaturation at 95 degrees, primer annealing at 60 degrees, extension at 70 degrees. And since it is a qPCR, meaning to say, unlike in conventional PCR that you have to amplify it and then the applicon, and then you have to do electrophoresis in order to show amplicon or the product. Here, it is being detected real time. How? Because here you will be adding a fluorophore. Okay, you have to quench the fluorophore, and the fluorophore would serve as an indicator, so that whenever the products are being amplified, it will be detected by the machine, real time, as it happens. Okay, so that's the beauty of this particular diagnostic testing. So again, what makes it real-time RT-PCR is a nuclear-derived method for detecting the presence of genetic materials in any pathogen, including the virus. So originally, the method is had actually used radioactive isotope that serve as a marker to detect targeted genetic materials. But because of its hazard, they subsequently developed a much refined marker for this particular nucleic acid. So instead of isotopic labeling with special markers, they simply utilize a fluorescent dye. So let's say, for example, you have a different fluorescent dye for M, N, or for the E sequences. Okay, so this technique allows scientists to see the result almost immediately while the process is still ongoing. Okay, unlike conventional RT-PCR, you have to wait for the amplicon. You have to wait for provide results at the end of the process. You have to wait for several hours before you can actually see the process. Unlike here, as the nucleic acid is being amplified, you can see, oh, this particular patient has a very high E sequences. Okay, as it happens. Okay, so it is a not so easy hunt. So this is actually the actual process, the RT-PCR technique. Okay, so it is considered as a gold standard for infectious diseases, and it is in high demand for the diagnosis of COVID-19. In fact, not just it is a high demand for um, for this particular assay, medical technologies have become, of course, price commodities nowadays because we are the ones who perform the RT-PCR. So again, so the process, we collect swab. So a swab is used to take a sample of the virus from the back of the nose, the nasopharyngeal swab, or the throat, okay, where the virus usually gathers. So the swab should go in deep enough to get adequate amount of virus. So now, you have to put it in the VTM. The swab is put in a vial containing a buffered solution, which preserves the virus until such time that the sample is now ready to be processed. So you now have so at this point, the virus are still viable, so you have to be careful. And then the genetic material in the sample, viral, bacterial, and human, is extracted and purified using a buffer solution. So we want to eliminate those things that are not needed in the assay. Because a swab may not only contain coronavirus, it may also contain other structures such as bacteria. Okay. The viral RNA is converted to DNA using an enzyme, reverse transcriptase. So there you have it. You get the RNA is converted to cDNA, which induces the process of reverse transcription. This step is needed as only DNA can be amplified. So you cannot actually amplify RNA, so that's why you have to convert it to DNA. Hence, RT here represents reverse transcriptase, not yet the real time. Because real time, you will only use the real time if you have the real time thermal cycler, such as this one. Okay. For amplification, what are the things that you will be adding here in the vial? Now that you have converted the RNA into cDNA, these are the things that you will be adding. So primers, you will be adding primers. Okay, what kind of primers? Well, these are the primers that you will be needing. Okay, primers that will detect the ORF1AB, E, N, and S gene sequences. Okay, so we'll be adding primers, and then you'll be adding fluorescent probes. So what are the functions of fluorescent probes? Fluorescent probes would serve as the markers. And then you will be adding the nucleotides. So the 4 nucleotides. Okay? The enzymes are put in vial to increase copies of viral genetic material. So the vial is put in an RT-PCR machine. Okay, and amplification process is automated. So it will take about 2 hours. So it will undergo the cycle. So this is now the PCR cycle. So you have the denaturation. So here, since the cDNA are double helix, okay, you need to unzip them, okay, at 95 degrees, so that primers will be able to stick, okay, to the single-stranded DNA that has been unzipped during the denaturation process. So primers pick up the needed nucleotides and initiate the process of replication. So we call that process annealing, and it is done at 55 to 65 degrees centigrade. So with the help of the enzyme polymerase and nucleotides, copies of strands are made at 72 degrees. So we call it extension. So you need to amplify, and the nucleic acid copies are now being logarithmically amplified after 40 cycles. So it is a logarithmic increase because from a single strand, you now have a few billion copies of the viral genetic materials. And how would you know if nucleic acid are actually amplified? So you would know because primers would have fluorescent probes. Okay, so as what I told you, these fluorescent probes would serve as a marker, okay, or dyes which are released after each cycle of replication. And these particular probes are being detected real time by this particular RT-qPCR. Okay, so in summary, as you can see, once you have obtained the sample, you extract the RNA. Then you do reverse transcription in order for the RNA to be converted to DNA, cDNA, and then you add primer PCR probe such as the fluorescent probe, and then the Taq polymerase, okay, and the nucleotides in this particular vial, and then you place it in the machine, and then after several cycles, if the patient is positive, you'll see an increase in the graph. Okay, so graph would have different colors because each color will represent what probe. Each color represents a certain fluorescent probe, and each fluorescent probe represents a certain sequences that you have previously identified in the primers. So the same process is here, but I want you to show the example of a positive result. So this patient would be positive for RT-PCR because after several cycles, you see the numbers or the nucleic acid is amplified, meaning to say the patient has the nucleic acid of the virus. Unlike this patient, nucleic acid or the genetic materials are not found in his swab, so even after several cycles, so no probes were detected, no fluorescent probes were detected. Okay, so that's the principle of the RT-PCR. So I hope you learned something, okay? So again, in summary, you obtain the specimen, you extract RNA and have it converted to DNA. You amplify the DNA by PCR, and then you interpret the results. If you are able to see an increase in the number of probes, I mean you have actually surpassed the threshold, then that is considered to be as a positive. Unlike negative result, you did not even after the threshold time, you're not able to amplify anything at all. And that is actually much different with antibody testing, because in antibody testing, you simply determine whether the person has antibodies against the SARS-CoV-2 virus. So later on, we will be explaining the antibody testing. But for now, let's talk about the antigen testing. Okay, so antigen testing or antigen tests are immunoassays that detect the presence of a specific viral antigen, okay, which amplifies current viral infection. So if the molecular test determines nucleic acid, okay, this antigen testing determines viral proteins. Okay, so antigen tests are currently authorized to be performed on nasopharyngeal swab or nasal swab specimen placed directly into assay's extraction buffer or reagent. So the antigen tests for SARS-CoV-2 are generally less sensitive, okay, than real-time PCR. So what's the implication if it's less sensitive? If it's less sensitive, so there's a chance for you to get a false negative result. Okay, so it is less sensitive than RT-PCR, and other nucleic acid amplification tests for detecting the presence of viral nucleic acid. However, RT-PCR can detect levels of viral nucleic acid that cannot be cultured, suggesting that the presence of viral nucleic acid does not always indicate contagiousness. Meaning to say, so again, this is another school of thought that if a person becomes positive with RT-PCR, it simply means that you have the genetic materials of the virus, but it does not necessarily mean that you are contagious, which is, of course, this particular school of thought is actually in exact opposite with the interpretation that a person positive with RT-PCR suggests an active COVID-19 infection. Well, so what are we supposed to do now in interpretation? Well, of course, that's the reason why we do not just simply interpret it with our own knowledge. We have to correlate each result with the clinical presentation of the patient and the history of the patient. Okay? In other words, wag magmarunong. So, this is the principle of the COVID-19 antigen testing. So, I told you a while ago that the analyte would detect viral antigens or the viral protein, specifically the S and the N proteins, because these are the two highly antigenic proteins of the SARS-CoV-2. So the samples are supposed to be present in the analyte. Of course, when you say analyte, it means that you have the swab and then you place it in the buffer solution. So from the buffer solution is added. So this is actually the principle of the lateral flow assay. So this is an example of the rapid antigen testing. But there are some procedures that would even entail a more sensitive assay, especially the antigen testing for chemiluminescent immunoassay. So this one, the analyte, so contains the analyte is supposed to contain the viral antigens or the viral proteins. So what do you have here in the immunochromatographic capillary flow? You have here antibodies. Okay, I suppose monoclonal antibodies that has been conjugated either to gold particle, latex particle, or fluorophore. Okay, so if you will be adding the antibodies here, and then you have here antibodies, and if these antigens are specific to antibodies, and this antigen will bind to the antibodies, and through the capillary flow, of course, you have added the substance here, and since you have an absorbent pad here, okay, it will flow until such time that it will now reach the test line antibodies and then the control line antibodies. So if the antibodies reach the test line antibodies, so it will form somehow like a sandwich. So it will yield, it will form color. And in order for the test to be valid, so there should also be a line in the control test. Okay, so in 15 to 30 minutes, we'll have the result. If it is the lateral flow assay or the immunochromatographic assay. But again, I told you that there are other options for antigen testing, such as the chemiluminescent assay. So this one is quite interesting. This is the antigen testing algorithm, meaning to say you categorize your patients into three categories. Okay, the symptomatic, and then the second category is asymptomatic patient but has a close contact with COVID-19, and then the third category is asymptomatic and no known exposure. So again, if you're symptomatic and you're positive with antigen, it means that you are infected with SARS-CoV-2. But if you become negative yet you are symptomatic, you have to confirm it by any of the NAAT. So if you're positive, it means that you're positive or infected with SARS-CoV-2. But if you're negative, then you have to trace. Okay? Has there been contact? If yes, well, it can be interpreted that You have no current or evidence of infection yet. I say yet. But if there's no non-contact, means that you are not infected with SARS-CoV-2. So what's the difference between the yellow line and the green line? Yellow line means that maybe sometime in the future it could be positive or maybe not. You do not know. Okay? So that's the reason why contact tracing is very important in order for you to interpret whether you fall under the green line, or the green line or the yellow line. Now, let's say for example you are asymptomatic but had close contact with someone who's positive with COVID-19. So if you're positive with antigen test, yet you are asymptomatic, well, of course, you want to have a peace of mind. So you would want to have a confirmatory testing by RT-PCR or by any of the NAAT. And if you're positive, it means that indeed you are infected with SARS-CoV-2. But if you are negative after confirmation, it means that you are not yet infected. No current evidence of infection. You may be infected in the future. You may not be infected in the future. Why? Why are we having a gray line, a gray area here, although it's yellow? Why are we having a gray area here? Because of the close contact with COVID-19. It means that there's a chance that you may be positive or not at all. So your life will be easier if you're asymptomatic and do not have you have no known exposure. So stay at home. Okay? You're asymptomatic and with no known exposure. So if you are negative here, meaning you are not infected with SARS-CoV-2. But if you're positive here, you need to have it confirmed again by another NAAT test. And then if you're positive, then indeed you are positive. But if you're negative, it means that you are not really infected with SARS-CoV-2. So there's no gray area, or should I say yellow area. Okay, so in summary, what is the difference between the antigen testing and NAAT? So again, when I say NAAT, this could be any of the tests that would require amplification of DNA, such as the RT-PCR or the LAMP test, what have you. Okay, so now the intended use. So nucleic acid amplification test, both of them would detect current infection. But the nucleic acid amplification test would detect RNA. Okay, this is the genetic materials of the virus, and of course, the genetic materials of the virus would be responsible for its infectivity. The antigen test detects viral proteins, the N and the S proteins. Specimen could be nasal, nasopharyngeal swab, or sputum or saliva would be possible for the nucleic acid amplification test. But for the antigen test, it could either be nasal or nasopharyngeal swab. Sensitivity, NAAT of course is more sensitive as compared to antigen testing, but both of them are highly specific. So the complexity of the test, well, it depends. For NAAT, depends on what is your manufacturer, what is the kit that you are using, but generally it really varies. But relatively compared to the antigen testing is much relatively easier to use as compared nakakalito yun. Antigen testing is relatively easier to use as compared to NAAT. Who can perform NAAT? Most are not, some are. I should say that in the Philippines, it should be RMPs for both. Okay. I'm not sure with the other countries, but in the Philippines, it should be RMPs. Turnaround time, 15 minutes up to 2 days, more than 2 days. But the same thing for antigen testing. Of course, it depends on the capacity of the lab and the workload in the lab. And now, here's the game changer. Of course, nucleic acid testing, RT-PCR is more expensive. In the Philippines, about 4,000 pesos or 4,500 pesos. But for antigen testing, it's just about 1,500 pesos. Okay, let's talk about antibody testing. So, in general, a positive antibody test is presumed to mean a person has been infected with SARS-CoV-2 or the virus that causes COVID-19 at some point in the past. So it does not necessarily mean that a person is currently infected if you are positive with antibody testing. So antibodies usually start developing within 1 to 3 weeks after the infection. Okay? So antibody test results should not be used to diagnose someone with an active infection. So that's the thing that you shouldn't do. People who receive positive results on an antibody test but don't have symptoms of COVID-19 and have not been around someone who may have COVID-19 are not likely to have a current infection. Okay? People who receive positive results on an antibody test and who are currently or recently sick or have been around someone with COVID-19 should follow CDC recommendations on caring for themselves and protecting others, meaning to say they need to isolate themselves, and especially they have to be extra careful when they are around other people again or after their self-isolation. So this would be the principle. So you add the sample here, you add the serum here. So serum is the specimen or blood is the specimen. And if a person is positive with antibodies, so the person might either have IgG or IgM antibodies. Okay, so let's say blue represents the anti-SARS-CoV-2 IgM, and then the orange here represents the anti-SARS-CoV-2 IgG. And then the conjugate pod have the anti-chicken IgM binds to colloidal gold particles, and the SARS-CoV-2 antigen binds to colloidal gold particles. So what will the function of the anti-IgM? The function of anti-IgM, as you can see, it will bind. Okay, the human antibodies will bind at the Fc portion, fragment crystalline Fc portion of the anti-IgM colloidal gold. Or, so as you can see, the green here is the chicken IgM bind to nitrocellulose strip. So ibig sabihin, meron na talagang antibodies yung nitrocellulose strip. And then the anti-human IgG nandito. And then the anti-human IgM, they are already here. So the anti-chicken binds at the these antibodies will bind at the Fc portion of the anti-chicken IgM, and it will also bind to the Fc portion of our antibodies. So ito yung humans. Bakit may chicken antibodies? Yung chicken antibodies are for the control. Yung human antibodies, ito yung antibodies natin mismo. So kapag hindi if there's no red label in the control, it means the test is invalid. So what's the purpose of anti-chicken that IgM binds to colloidal gold? The purpose is for the control line. Okay? So what's the purpose of the IgG line and IgM line? These are anti-human IgG because it's anti-human. Our IgM antibodies will bind, the Fc portion of our IgM antibodies will bind here, and then the Fc portion of our IgG antibodies will bind here. And then of course, since it is also a lateral flow, so as we pass the conjugate pod, we make somehow a sandwich, but a sandwich is like you have here the anti-human IgG, this one is anti-human IgM, and then you have your actual IgM, and then you have the antigen. Okay? So, if you're positive with IgM. If you're positive with IgG, the anti-human IgG is actually waiting at the IgG line, but your human IgG will pass through here, and the Fc portion of your IgG will bind at the FAB portion of the anti-human IgG, and together with the antigen. Is antigen needed? Yes, because antigen is needed in order for the reaction or immune complex to take place in the respective IgG and IgM. Okay, so antibody testing do's and don'ts. So antibody testing, until scientists get more data on how much protection antibodies provide against being infected against with this virus, everyone should continue to take steps to protect themselves and others. So it doesn't mean that once you have already antibody testing, you are already positive with antibodies, it doesn't necessarily mean that these antibodies are already protective antibodies. So there's still a chance that you may still be reinfected again. Okay, so if in case that you are positive with antibody test, then again, wherever you are, whenever you have to protect themselves and others as well by wearing a mask, staying at least 6 feet away from other people or social distancing, or and then again, stay their home, wash their hands, even if you are positive with antibody test. So people who wear personal protective equipment at work should continue to wear PPEs even if you are positive with antibodies to the virus. Okay, so what is the no-no when it comes to antibody testing? Antibody test results should not be used to determine if someone can return to work or not. Antibody test results should not be used to group people together in settings such as school, dormitories, or correctional facilities. So you cannot say, those are positive with IgG and IgM should stay here, those who are not positive should stay here. No, that shouldn't be the case. Okay, so there you have it. That's the end of our discussion. I hope you learned something. So at this point, just continue to stay safe, observe minimum health protocol. Okay, let's pray that everyone will soon get everyone will be vaccinated the soonest time possible. And most importantly, do not forget to pray. God bless everyone and stay safe.